This is Group Two's presentation called Amending the ADA, the Civil Rights Solution to Ensure MLUD Access in Prisons and Advance Health Justice in the Opioid Crisis. Today, we'll begin by looking at how the opioid epidemic is not just a public health crisis, but also a civil rights and health justice issue. We'll then talk about how the American with Disabilities Act, or ADA, can be used to eliminate discriminatory barriers that prevent people from getting the treatment they need. Next, we'll explain why ensuring access to medications for opioid use disorder, especially in carceral settings like prisons and jails, requires legal enforcement. We'll also discuss how the ADA and the Affordable Care Act, otherwise known as the ACA, both support access to treatment. We'll cover the roles of federal agencies responsible for enforcing these rights. Finally, we'll address some of the political limitations we face and share a proposed legal solution to help move things forward. From a social justice and health inequity issue, OUD harms marginalized communities or individuals troubled within the criminal justice system. From a statistical standpoint, the National Institute of Drug Abuse says that roughly 60% of individuals who have been incarcerated in the US prison population have a substance use disorder. However, fewer than half of jails and fewer than 10% of state prisons provide access to all three medications for opioid use disorder. These individuals are consistently denied medications for opioid use disorder, despite it being the gold standard treatment. Denial of treatment is a serious issue that contributes to unwanted negative social and health consequences for these marginalized individuals. Therefore, treatment during incarceration is crucial to reducing possibilities for relapse. This is a civil rights issue with a social justice and health inequity element. In other words, discrimination. People with OUD are protected under the ADA. However, treatment is denied when they need it most in prisons and jails. This is a human rights issue. Not only does it violate federal law, but it widens health inequities and leads to unwanted preventable deaths. Individuals who have currently been incarcerated are 129 times more likely to die from an overdose inside the first 2 weeks of being released back out of prison. Many jails and prisons deny individuals these medications used to deal with opioid use disease that would improve fitness outcomes. And denial of MLUD to individuals post-incarceration disproportionately harms these marginalized groups and worsens racial and socioeconomic health inequities. By amending the ADA, we could change OUD to be a protected disability under the Controlled Substance Disability provision to ensure that prisons treat every person, and even those in prison in particular, with equity and access to treatment. MLUD has been shown to be a very cost-effective intervention, and supporting the provision of evidence-based treatment adheres to health equity, best supported human rights standards, and the standards of correctional healthcare delivery. For our policy recommendation, we are proposing that the federal government enforce and clarify existing civil rights protections, mainly the ADA and Section 1557 of the Affordable Care. These laws already protect people with opioid use disorder, but they aren't always enforced in jails and prisons. We believe that by strengthening enforcement and issuing clear federal guidance, we can make sure that incarcerated individuals have access to medications for opioid use disorder. The strategy builds on laws that are already in place and offers a realistic, immediate way to protect health and rights without needing new legislation. First, we'll recommend enforcing ADA Title II, which already recognizes opioid use disorder as a protected disability. Second, the Department of Health and Human Services should issue guidance under the ACA, clearly stating that denying MLUD is a form of illegal discrimination. We also suggest that the Department of Justice, in conjunction with the HHS, investigate prisons and jails that aren't already following these laws. The important thing is, again, we do not need a new law. We simply need to utilize existing civil rights laws more effectively to save lives and promote recovery. This is the best route for public health because the data shows that people in jail or prison who have opioid use disorder, again, are 129 times more likely to die from an overdose after they are released. Giving MLUD or addiction medicine to people while they are still in jail or prison can lower overdose deaths by up to 60%, as seen in real-life programs like the one in Rhode Island. Making sure these are civil rights making sure these civil rights are followed shows that addiction treatment is a basic human right, not something extra. It helps reduce stigma, support recovery, and improve health for vulnerable and marginalized groups. Therefore, this position leverages the existing legal frameworks to provide effective, cost-saving, and equitable healthcare to incarcerated individuals. From a public health impact standpoint, MOUD reduces overdose by up to 60%. From a systematic inequity standpoint, access to MOUD ensures equity for marginalized populations, particularly low income, Black, Indigenous, and people of color, by eliminating discriminatory barriers in healthcare. As a legal precedent, denying MOUD violates both the ADA and ACA. From a cost effectiveness standpoint, providing MOUD reduces healthcare costs and saves taxpayer money while also improving public health outcomes. And finally, from an ethical standpoint, denying MOUD is a violation of human rights, denying incarcerated individuals access to evidence-based care that supports their recovery. With respect to the government implementation plan and agencies responsible for implementing MOUD, we call upon the Department of Justice and the Department of Health and Human Services to enforce the ADA and ACA by exercising their authority to clarify that MOUD is a protected right within correctional facilities. The DOJ must therefore enforce, through investigation and prosecution, providers who fail to offer MOUD or who violate the law, equal rights, and non-discrimination. This could also be done through the cutoff of federal funding. In terms of funding MOUD programs, we call upon the Bureau of Justice Assistance to dedicate funding to establish and adopt MOUD programs in prisons, such as funding opportunities for training staff and enhancing infrastructure. And finally, in terms of public health awareness and education, SAM-HSA should be responsible for educating providers in prisons on the importance of MOUD. This doesn't go without limitations, however. We recognize that funding and resources, especially in today's current political climate, may be limited in nature and may pose a potential threat to the scalability of the program. Moreover, legal pushback and resistance, especially if MOUD is pushed out as a federal initiative, may be drastic. In particular, we recognize that movements to repeal or replace certain parts of the ACA as well as the ADA may result in MOUD not being passed immediately. Ultimately, access to MOUD is a civil right. We recognize that the ADA protects people with OUD when they are in treatment. Ultimately, MOUD is not only medically ethical and cost effective, but a legal and moral obligation rooted in human and civil rights. We utilize existing laws, again, using the ADA and the ACA, and we enforce it through the DOJ and the HHS with funding from the Bureau of Justice Assistance and framing from a SAM-HSA, understanding that MOUD and its denial is a crisis for both public health and civil rights. These are our references, and thank you for watching.